in ED, still not a very common breed, but my background is basically started off in an admissions ward, which obviously became an acute care ward, an acute care unit, and works quite closely with the ED, so that's basically where I come from. This is just a little flavour of us in Gloucestershire. We've got two basically district general hospitals. The Cheltenham one around about 1850, so you can see it's all kind of twee and pillory. And then the Gloucester one, which is basically a 70s monstrosity with a bit more modern extension built on there. But because of the geography and some politics, we're actually privileged to have two emergency departments working probably about 14 miles apart. Now, if anyone saw the interview in the Times from the head of NHS providers, I'm wondering whether it's us he's targeting. But basically we have quite a variance in populations, and we have quite busy ED departments, as you can see from those numbers. So quite an interesting area to work. As all researchers do when they start to think about doing something, they look at the available tools and basically pull holes in them. So unfortunately I did look at beers, I looked at stop-start, and my aim was to really produce something that I could hand out to pharmacists and junior doctors and nurses in these areas to actually look at reviewing drugs which were potentially risky. So it became potentially inappropriate drugs in the elderly, which is a bit of an unfortunate acronym for many reasons. Especially now there is one called Pharmacists in ED, which is PIED. But if you're interested in this tool, it was a collaborative work with my consultant colleagues and the frailty specialists, and it is available online, and I believe we do have some hard copies which will be, we did have some hard copies, but I can always email if people are interested. So the project was basically to target the frail older person, anybody who came through the admissions ward with a drug-related admission, which I as a pharmacist obviously pick up, but also those who'd come in with things like falls, delirium, and those patients who basically were thought to be approaching a stage in life where they weren't going to be very actively treated. So not necessarily dying, but certainly at a stage where they were maybe in their last few weeks or months of life. And my aim was to review the indication and the dose for every drug that I saw in the light of comorbidities, plus the recent observations and the test results that we had. So basically a standard pharmacy review, which would happen on most wards, but with a targeted patient group. So the first thing we did was to look at the anticholinergic burden, which obviously most of you will know is linked to increased morbidity in older patients. And we found that 43%, so just under half of our patients, had got ACB scores that were potentially putting them at risk. The second thing, which was the success criteria I felt, was that through doing this, 80% of patients that I reviewed had one or more changes in their prescription. And I'm sure you'll be wanting to know what they are. So these are basically the target drugs. Probably won't come as any surprise to those of you working in falls, frailty and elderly care, that basically the common problems, antihypertensives, diuretics, either too much or too little for osteoporosis, antiplatelets, diabetes medication, and a whole wide range basically of drugs. So I looked at 87 patients and altered something with 212 drugs. So a reasonable size study, but obviously not as big as I would have liked it to be. The problem's not doing the work, the problem's monitoring and recording the work. Sorry, got a bit enthusiastic then. So this was what I struggled to get across to my colleagues and particularly some of the other consultants within the organisation, that actually we weren't doing this to save money, because there is a great suspicion with polypharmacy reviews that what you're actually after is kind of saving the hospital lots of money. And I had to say no, it's actually in 82% of cases it was a safety issue, and actually less than 1% was for pure cost. So a detectable adverse effect, so that might be a postural drop, It might be a patient with urinary retention, it might be a drug-induced confusion state, it might be another sort of side effect, so a detectable adverse effect. And then what I went to was look at risk assessment. So actually they may not be having this problem now, but if nobody looks at it, might they have a problem in the near future? So that may be somebody who'd come in, say, with a PE, but actually it was also noticed they had a big postural drop and they were on 3 antihypertensives, and actually it was worthwhile looking at the whole picture. So that was 82%. 11% basically were stopped because nobody knew why they were on them in the first place, which is not uncommon. And 6% were basically the ones where you would say, really? You're going to make this 90-year-old chew these Adcal tablets twice a day when she's got 2 types of malignancy and is probably in her last month? Would you want your grandma to have to do that kind of interventions? And again, there was a couple of changes for cost. This was one of the problems. If we'd actually found lots of cost savings for the hospital, then I'm sure the resourcing would have been available. So outcomes then. I actually wanted to follow through this cohort both throughout the hospital stay and also on discharge, but again it came down to resourcing. So basically 80% of the patients that I made some changes on either died during that hospital stay or were basically transferred out to community facility or hospice, or basically died pretty close after we saw them. So that group obviously is an appropriate group to look at medication load in, because we don't want them to be having to take non-essential medication that doesn't help symptom control. And that was basically not thought to be any difference compared to what we would expect normally. 3% of the changes that I had made were reversed before discharge. So for one of them, somebody come in slightly bradycardic, the bradycardia got better, they restarted a beta blocker. Sounds sensible to me. Restarting a PPI, I didn't particularly agree with that decision. And the restarting the diuretic at a lower dose, again, seems sensible because as we know, heart failure, you have to kind of balance the diuretics. And again, the glycoside was probably something I stopped because the BMs were low in the early stages, and I would hope that as these patients go through their stay, that any changes that we do make on the ACU are looked at again. It's not just a case of the changes is made on day 1 and on day 4 you're not allowed to touch those. So I was quite relieved to see that some of the changes were made, but actually it made me feel more comfortable about the changes that had been made, because not many consultants had restarted the medications that had been altered. So the problems that you may come across doing this kind of thing, there still seems to be a little bit of an old-fashioned attitude among some physicians particularly, and certainly surgeons. Why do I want to change it? Because it's not directly related to the problem that this patient's got. And actually this is what we're trying to do. You know, you give someone a statin after they've had a heart attack to try and reduce their future risk. But if you try and relate that across to a patient who's come in with a UTI but also has a low blood sugar, people are more reluctant to look at the blood sugar. So I did have a little bit of that. And again, the specialist versus the holistic. So I'm sure most of you whose background is in care of the older patient would recognise it's about the individual patient, it's not about their cardiovascular system. So I had one stroke consultant who insisted that they wanted their blood pressures controlled to within an inch of the patient actually being able to move. And there was a lot of argument to say, well actually, yes, the cardiovascular system may benefit by a small amount, but actually the rest of them won't. The thing that upset me, I suppose, was getting funding and getting timing to do the project, because our trusts are very centred on direct savings, and anything that you do that reduces future risk or improves quality, it's much more difficult to get investment in that. I really wanted to have more time to talk to carers particularly, because I know that when you can talk to the patient, know the patient understands where you're coming from, you can feel content that that change has actually made sense to them. and that they've actually had the opportunity to discuss it with you. If you have a patient who's perhaps not able to have that discussion, I would have loved to be able to talk to the carers, because obviously they worry if you stop medication that perhaps you've given up on the patient, etc. So that's what I would have really liked to do. And the other real flaw was in our system of communicating with primary care, because again, when I wasn't around, you would find that, a discharge summary was done, but it didn't mention drug changes. So my suspicion is when I go out, which I hope I will do, to follow these patients through to GP surgeries, that we'll find out exactly how many of the patients or the drug labels or some other way, and they actually realise these changes have been made. And there were a couple of cases where I was kind of really livid because I'd stopped things and then the patient came back in still on them, and they came in with the same problem or a worse problem, and it was really quite frustrating. So this is just a snapshot of one patient, just to give you some background on that. I'm sure you can tell from that list of medications what I'm going to come back and say, but this was a collapse. Past history of hypertension, however not hypertensive, low sodium, high urea. On that little collection, basically went out on clopidogrel for the obvious reasons that are up there. And then, just because I'm a pharmacist, I thought I ought to fly the flag slightly for my colleagues working in ED. There's been the national results recently of this PIED project, which has obviously stole my initials. So that was for 49 EDs and a total of 18,613 patient data sets. And they're basically looking at whether pharmacists, given advanced training in the same way as ANPs, can actually manage some of the workload in ED. And the conclusion was that they thought that after this tailored course, which is basically on clinical assessment skills and diagnostics, they felt that pharmacist prescribers could treat 36% of patients seen in minors and up to 27% of all attenders to ED. So this is obviously interesting from my perspective as a pharmacist, and I thought I'd leave you with that to see what you thought. Thank you very much.
Thank you very much, Pam, for an interesting talk. We have time for one quick question, but we'll need to move on to our next speaker, who's Heather Owen. But do we have any, whilst Heather's getting mic'd up, do we have any questions or comments from the audience? Oh, yeah, we've got a couple. So you get yourself mic'd up, Heather, and I'll bring your microphone down.
Thank you. It's quite interesting, but I'm just not quite sure whether you're doing it in the right place, in my opinion. This should be primary care. So if you look at the notes from primary care before you change the treatment, you see if they really do need antidepressants from the GP notes.
We do see a certain amount of information from the summary care records. So, for example, an antidepressant, I wouldn't automatically stop. I may possibly suggest it's reduced. But if somebody's on 10 milligrams of amitriptyline, for example, which has been started usually because the GP wanted not to use a Zopiclone, then some of that can be done in an acute care environment. As more pharmacists establish themselves in primary care, I do believe that is going to be one of the places that this kind of project has got legs. And I really look forward to the time when, as I see patients coming in, it's obvious that they've actually had an appropriate polypharmacy review. And then hopefully I can retire.